started, we had only not more than 100 pediatric endocrinologists in the country, and the burden was huge. So there were thousands of cases of pediatric endocrinology were there, but then there were very few to cater them. So what we thought that there was a need somehow to have bridge in between them to develop special interest in pediatricians and physicians, and then they can really match and manage the overall case. Since then, there have been definite improvements which have happened, and now so many new things have happened. But this was what when I started in 2007 in that regards. So we started off and we realized that awareness was a major problem. So whenever we talk of a disorder, we know that there are three things: awareness, accessibility, and affordability. Now, everybody says it's affordability, especially when it comes to hormones. They're expensive, were difficult to get, but it's actually awareness. So we started with pediatricians' awareness. This was in 2012, and we can see many of the people who are still there. Many of the faculty is the same from that time. It's continuing from there. And then we conducted a number of programs across the country. We developed 6 modules, which are still the base of many of our courses. Till now, we have conducted 120 workshops, 15 practical pediatric endocrine courses across the country, and 5 advanced pediatric endocrine symposium. This is the 6th one that we conducted. So this was the first one in 2017, and we can see Dr. Hemchand here. So he was there right away at that point of time. Again, Dr. Hemchand talked about bone age. We discussed about this. Then there was a couple of year gap because of COVID. Since then, we have been having annual events every year. Every time we have got very good people coming from across the country. Now, after conducting so many programs, what we realize that once you conduct the program, people forget about that. Whatever you teach, they will just don't remember. And it is too much effort to go in terms of money, in terms of time, manpower, and everything. So we thought of using the power of social media to highlight that, and we set up this channel, which is now one of the largest channels as far as pediatric endocrinology is concerned. And it has been viewed across the globe. It provides, there are over 400 videos and everything on pediatric endocrinology. So anything and everything, it's available there. We then thought of in terms of systematic approach in terms of pediatric endocrinology learning. So we started off with our fellowship program in 2017. And as Dr. Ravindra was saying, that we are now recognized by the National Board of Examination. And it was in fact a dream for the last 10-15 years that we were pushing for pediatric endocrinology fellowships, which were not available from NB. And now finally the dream has come, and BJ Vadia and our center is now the 2 centers which are going to provide training in pediatric endocrinology. Now, what we realize that even physical fellowships, many people who have done training and who are in practice or doing some medical education, they are unable to really come in for 2 years because it's very difficult for them to join and leave the practice. So we started with online learning in terms of medi classes followed by books. And then we thought if you want to empower people to develop applications so that they can use, and we discussed some of the innovations just recently. Our fellowship started in 2017, and both of them are here. Dr. Neha and Dr. Chetan, they started with the first program. Dr. Riddhi and Dr. Sajali was also there in the second group. Dr. Pratik is currently in UK. Dr. Sayan and Dr. Naveen are now pursuing DM courses in PGI Chandigarh and at AIMS Delhi. Dr. Manoj was here. As we can see, Dr. Vibha has joined with us as a consultant. Dhwani is currently in Patna, so we have people across the country. And we have got Dr. Alapan and Sandeep who are still there, who are working. And Dr. Nimisha is the last one to join. So we've got 13 people who have joined, and hopefully very soon we will have the National Board Accredited Fellowship, which will start here. Our learning portal provides validated tools for evaluation, assessment, and pediatric endocrinology, including a full fellowship in pediatric endocrinology. So we launched around 3 years ago, fellowship program in pediatric endocrinology, which was a very, I would say, a tough program. It has 2-year learning. Every 2 months, there are online exams. There are continuously lectures every week. Every 6 months, there is a 5 days program in which they come, they see a lot of patients, we discuss with them, and then this program happens. So there are 4 sessions which are there. We have developed a mobile application, which in fact is the most downloaded endocrinology app, and we talked about publications there. We are developing other tools like personalized intelligent EMR, which will help guide evaluation and management of pediatric endocrine disorders. We have developed BIG, the bone age assisted interpretation of growth, which recently Dr. Vibha was just talking about how it will help assess puberty, growth, bone age, and obesity at one single click. You will be able to get all the results. We are developing a personalized expert for nutrition in which it will analyze all your meal items in terms of lot of input which we don't know about glycemic load, all the other aspects, and then it will also provide based upon the requirement the recommended 7-day allowance. So automatic diet chart will come in for patients, which is coming up. We have already developed the Diabuddy app, which provides insulin dose guidance based upon glucose as well as carbohydrate counting, which is there inbuilt in the app, and this is being validated right away. So hopefully next time we would be launching it in a proper for a general use in that perspective. We have got number of books, basic, pediatric, and advanced. So we have tried to do a lot in this area over the last decade or so. Many of our efforts have been recognized. As I showed, Dr. Riddhi won the award for Best Bone Age Presentation at Kolkata, Dr. Sayan for Puberty Interpreter, Dr. Alapan at APES, Dr. Dhwani won the Kaichi Kida Award for the DSD Interpreter, Bone Age Assisted Interpretation for Growth, Dr. Vibha. Then also, so all of presentations have been there. There are a number of publications coming out of our tools, which have been validated and developed. So our fellowship in pediatric endocrinology, as I said, is a comprehensive one. There are over 100 modules, approximately 1,000 hours of videos that people have to watch. Pre-test, post-test, live lectures are there. There are on-site 4 visits with hands-on exposure. Assessments are done bi-monthly, 6-monthly, and an exit exam. And then there are other opportunities to collaborate in terms of research, learning, and teaching. So we have had multiple, we have now 9 on-site courses. This happens every 6 months. Started from 2019. To date, we have had all these on-site courses, and we can see many of the places which are here also. So this was the last course which was done just in June 25. And all of them, I think most of them are here. And this was the extensive program in which we had 300 patients coming from growth, puberty, thyroid, electrolyte, all the disorders. And they were discussed in intensive fashion. And discussion was there. So till now, 48 people have been awarded fellowships in this program. Ongoing 72 people are doing fellowship. There are many other courses also where people are enrolled. That number goes to thousands or something. 12 nationalities have been enrolled on that. So this is a way in which we are trying to increase the number of people who are working towards pediatric endocrinology.
PCOS, I know it is one of the most commonest disorders that we as gynecologists encounter, and you as pediatricians also see in your adolescent population. And we've had multiple lectures and lot of talks on PCOS, so I don't want to bore on its things. I here really wanted, among so many professors and associate professors and so many seniors in front of me, want to just stimulate you to start doing research in this topic. So we know so much about PCOS and we really don't know much. And a lot of things are happening worldwide about why this enigmatic disorder occurs. So we all know it is basically the triad of chronic anovulation, hyperandrogenism, and polycystic ovaries, which is the morphological aspect of it. And according to the criteria of definition, amongst teenage girls, about 3 to 11% can have PCOS. But there is a diagnostic dilemma because of the physiological hyperandrogenism, anovulation, and multicystic ovarian that we commonly see in young girls. And we've had challenges that I would like to touch base is what are the updated criteria for diagnosis of PCOS in adolescent? And what actually, so we know the whole pathophysiology of PCOS, but what actually is how our lifestyle is leading to that, and what actually is the cause, we really don't know. And how to differentiate these lean girls with obese PCOS in adolescents specifically, because they would sometimes present with partial PCOS phenotype, say maybe just hyperandrogenism or maybe just irregular periods and not the whole phenomena. And what are the newer treatment modalities? So Rotterdam criteria in 2003 came up with this triad, and they said any 2 out of the 3, after excluding all the other causes, would be the definition. But this one was not very fit enough for adolescent, because a large population of adolescent would have irregular periods, would be because of the immaturity of the HPA axis soon after menarche. And also the diagnosis of polycystic ovarian morphology in young girls is a bit difficult, because doing scans in these girls, especially if they are obese, transabdominally you're unable to pick up the PCOS, and transvaginally it is not possible for the young girls. So a difficult diagnosis, and that's why there was a lot of overdiagnosis or underdiagnosis of these girls. And then in 2018, ESHRE, ASRM again came up with the new criteria for adolescent girls. They said not to take the phenotype D, where you have just the chronic anovulation and the morphological part, that is the polycystic ovarian morphology on ultrasound. This combination not to be used as PCOS in young girls, because as I said, about 25% of young girls can have polycystic ovarian pattern, which could be just normal. So they said 8 years till Minaki. Don't use ultrasound criteria for the diagnosis of PCOS. And use age specific criteria for characterizing that these cycles are really anovulatory. So having irregular periods is quite common in basically young girls. So when to say this is really irregular? So you cannot have adult criteria put up on these girls. And they made hyperandrogenism as a mandatory diagnosis to have. So if you're labeling someone PCOS, it has to be hyperandrogenism, either clinical or biochemical. Biochemical, the cutoff was lowered from 80 nanograms to 55. And for having significant hirsutism, that is a Ferriman Galloway of more than 15, or severe recalcitrant acne. They also came up with a term to not label young girls with PCOS, and they started saying that you call them at risk for PCOS if somebody is not fitting into these diagnoses, and keep them on follow-up. And there are studies that show that about 50% of those girls who were labeled as PCOS in adolescent population turned out to be healthy adults, individuals. Now, 8 specific criteria for anovulatory cycles. Basically, if you look at coming from the Minaki point of view, if there is no menses after 3 years of breast development, no menses, that is primary amenorrhea, in the first 1 year, a cycle which is longer than 90 days, in first to 3 years after Minaki, a cycle which is longer than 45 or less than 21, and a cycle which is more than 35. So this is the adult diagnosis of oligomenorrhea. So cycle which is more than 35 or a shorter cycle, you would call them as so sometimes you have people with a 40-day cycle in the first year of Minaki, that could be just normal. So use age specific criteria for anovulatory cycles. Now in 2023, which we have now started calling it Rotterdam 2023, 20 years after the initial criteria, they have now added AMH levels in their armamentarium for diagnosis of adult PCOS. So if either do a ultrasound or an AMH level, if they are high or you have the polycystic ovarian morphology, then you can label it besides the chronic anovulation and hyperandrogenism, but specifically said that not to use it for adolescent girls, which is very commonly the gynecologists are doing, using AMH for diagnosis of PCOS in adolescent girls, which is not recommended by the Rotterdam 2023 because it is non-specific and highly sometimes very much elevated AMH levels are seen in young girls, which might not be correlating with their symptoms. So coming on to basically the prevalence, as I said, the prevalence of the disease depends mainly on how you are diagnosing it. And this is a very brilliant study done by AIMS, published just recently in 2024 by the Department of Endocrinology, Professor Ashraf Ghani and Professor Neena Malhotra from Department of Reproductive Medicine. And they did basically it was a nationwide cross-sectional study of 5 zones in India. They used the Asha Bahu nurses using the voter ID cards from 18 to 45 years old women, going to their home, using questionnaires, and then they came out with basically this data. And alarmingly, using Rotterdam 2023, about 1 in 5 women actually had PCOS. So about almost like 19.6%. So they did the screening, and all the at-risks were called into the medical colleges, mainly the AIMS, and then they were worked up. And they were found out to be, almost, say about 56% were thin fat phenotype, so the lean PCOS. and almost 90%, almost 92% had dyslipidemias, which is alarming. About a third had any non alcoholic fatty liver metabolic syndrome, and only about 3% had diabetes. So basically they are coming up with a follow-up study by using other criteria, but this is for adult women. We don't have any such large scale studies for adolescent girls. So this is for adults, and which is really alarming, with the prevalence of about 20% of PCOS in general population. So, what are the recent advances in the pathophysiology? So, there are four aspects where we know that it is a multifactorial disorder. It is a lot of heterogeneity. One cause may not be the cause for PCOS in another patient. A lot of heterogeneity here. There are a lot of implications, newer studies coming about gut dysbiosis, environmental toxins, and what is the molecular basis of lifestyle leading to PCOS. We really don't know. So we know that people who have a bad lifestyle, weight gain, they don't exercise, they eventually land up into PCOS. But why? We really don't know that. So basically, if we'll just we all know about this pathophysiology. I'm not going into detail, but there is something that is leading to this triad of hormonal imbalance, and these four things that have been implicated, leading to all the clinical presentations that we see of hirsutism, acne, by basically increasing the testosterone level, lowering the SHBG, and hyperinsulinism. So, for environmental toxins, actually, BPA, which is a very common endocrine disruptors present in plastics, there are many studies coming up. There is a recent review collating all the studies that are showing direct relationship of BPA to PCOS. And then you have circular RNAs. These are epigenetic factors, which probably in the next 10 years either might be used as a biomarker for diagnosing PCOS. And gut dysbiosis, lot of studies coming, lot of in India, one study comes and we get the drug available to treat it. So we have a lot of people coming on to you with dextrins in their dietary supplements to improve the gut dysbiosis. And in fact, there are correlations of having a bad gut and lower levels of GLP-1s in those patients. And diet and lifestyle is an interplay of lowered GLP-1 and the uncoupling protein factor, which I'll come to in a little bit detail. So these are some studies that I identified while doing my research, that these are some areas that we should also work in. So coming on to BPA, it is basically it is a xenoestrogen, very similar in structure to 17 beta estradiol, and it is present in almost everything. All the especially the feeding bottles that are very common, and we are sitting with these mineral water bottles. They have to be ideally BPA free, but they're not regulated properly. And WHO recommends that the daily dose should be less than 1.5 microgram per kg body weight, which is much higher when you look at the studies that we are taking. Toxic levels are very high, but chronic toxicity by taking long-term levels of 1.5 microgram per kg body weight can lead to a lot of problems. Now, this very nice review article that collated all the studies was published in 2024. It is from India itself, and it has actually all the studies are not done in India. This is a review that the team did from Manipal. These are studies done, in vitro studies on the granulocytes, rat models, and even a lot of studies done in assisted reproductive technologies related studies, like taking out follicular fluids, metabolic studies while you're doing IVF, to look at correlation, how much BPA we have in our system. And you'll be surprised that BPA studies have shown that they basically works via mitochondrial dysfunctions. Basically, directly affects the granulosa cell, causes a PCO-like morphology. So, a lot of studies, in vivo studies, by taking ovarian biopsies in PCOS patients in vitro studies where they have done, and even in rat models. So they have created using BPA in all the cells that are implicated in the PCOS morphology. So there are some studies now coming up, mainly in IVF related, so reproductive medicine, where they found that implantation rates and oocyte immaturity in PCOS patient is directly correlated to blood levels of BPA being lower in good prognostic patients. Coming on to the second aspect, the genetic basis of PCOS. Again, this study was published in 2025, where they found out among patients of European ancestry, there are certain genetic variations in these specific gene loci for lean PCOS, which is different from obese PCOS. So lean PCOS probably is working from a different pathophysiological point of view compared to the DNDA, which is the final, basically, eventually it collates into both lean and the obese PCOS that leads to hyperinsulinism and dysfunction at the level of granulosa cell and oocyte maturity. So basically, both distinct and shared genetic factors are present here in overweight and obese PCOS, giving us an idea that there is some genetic basis to this disorder. Not everyone in PCOS have a genetic basis, but when you look at, there is always a historical data of metabolic clubbing, of metabolic disorders amongst the family, and you have, fathers with metabolic syndrome having daughters with PCOS. Those type of correlation studies were always there, but this specific gene identification where the loci was done by them. Again, the epigenetic two-hit hypothesis. Some people might be predisposing for PCOS, but they do not present unless they have the epigenetic modification, where the role of the circular RNAs are coming. Now, circular RNA is the messenger RNA, where the 5 and the 3 cap prime ends, they covalently bond to form a circular RNA structure, which will not be translated, but it actually goes back to the gene and causes the upregulation of the gene. So it's sort of a positive feedback loop. And in the cytoplasm, it mops up the microRNAs that have the inhibitory effect on the gene upregulation. So it's sort of acting at the genetic level where the gene was normal, but its expression was increased or decreased due to certain environmental factors. And why circular RNAs? Because they work at the level of, the gene transcription, translation, and even post-translation modification, and they're very stable. So you can actually, they're not like messenger RNA that can be very easily metabolized. Because of their circular nature, they can be very easily picked up from blood plasma, and that's why a lot of studies are now coming in identification, raised level of certain disease specific circular RNAs that can be identified. So a circular RNA which is specific for PCOS has been identified, which basically they're doing studies at their initial levels, but they can be diagnostic molecular marker for identifying this disease. Again, GLP-1 and UCP1, these are two molecules. A lot of research is happening here. So basically, our diet actually is, if it is not a great diet, so not very rich in veggies, not, if it's a high fat diet, GLP-1 production actually decreases. And that causes a lot of other pathophysiological things that happen and eventually leads to hyperandrogenism. GLP-1 actually acts centrally at the level of brain. It causes satiety and all, but it also works directly on the GnRH pulse, leading to the alteration of LH and FSH ratio. It acts on the pancreas and it also acts on the muscles, where it is basically leading to both hyperinsulinism and hyperandrogenism in a PCO phenotype. And the muscle myokine. So when you're exercising, muscle is releasing certain chemicals. Now, this is an uncoupling protein 1, which is released by the muscles. It acts on the adipocytes by making the adipocytes brown. So the adipocytes that produce a lot of thermogenesis. Normally, adipocyte is there to store the fat cells, but there are certain kinds of adipocytes that actually will not store it and cause the burning of the fat. So, the better kind of good fat. And that's why when you're exercising, this is the basic correlation between why you're losing fat. So, basically, I'll come to some studies where they have proven that in Indian people, lean PCOS people, the GLP-1 is down regulated, the UCP is also down regulated. Coming on to management, we all know about lifestyle. It affects all aspects, hormonal and metabolic aspects of PCOS. The combined oral contraceptive pills make your cycles better, correct testosterone, but have no effect on the metabolic aspects of it. The metformin has a milder effect on the hormones via indirect loop of improving the insulin resistance, but better effect on the metal. So combination of both these drugs is much better than using the COCPs in patients who are high risk for metabolic disorders. And then the GLP-1 and SGLT2. The anti-obesity drugs are now also coming in the injectable formats, but not approved for PCOS, not approved for adolescent age group up till now, only for obesity. Again, myoinositol is one of the drugs that is very commonly used in adolescent age group because we generally don't prefer to use hormones in that age group. In fact, many studies have shown that it is as good as placebo actually. So I'll come to those studies as well. So metformin, and this is a 2025 study, metformin combined with COCs, combined oral contraceptive pills, is a much better option, especially if the BMI is high. So it is superior to COCP alone for metabolic parameters. And if the BMI is high, it is even better. So if you've got a patient with hirsutism, not use just the COCPs and anti-androgens, add metformin, it has a better result. This is a good systemic. It's a 30 RCTs and 6 RCTs were adolescent girls. Again, inositol, a lot of now. This is the 2023 update, and this update was included in the international PCOS guidelines, and where they recommended that metformin was definitely significantly better. So when you're choosing not to use hormonal preparations, even in patients who have just the adiposity and not the BMI is not high, you can use metformin over myoinositol, which is much better. And when you compare it with placebo, myoinositol was not it was as good as placebo. So myoinositol use is very high in our country, especially in adolescent age group, to basically when the patient chooses not to take hormones when the doctor is recommending. Again, this study, this was a 2014 study, and the same group did a follow-up study on the use of oral contraceptive in patients with lean PCOS, and they found that GLP-1 levels, both at fasting and in response to meal, were lower in lean Asian women. So we generally are genetically probably, or maybe our diet is like that, or we have gut dysbiosis. We are producing less GLP-1 compared to other people. And even the lean Asian women are producing less GLP-1. So we have insulin resistance coming out from there, and maybe the diet is like that. So basically, now this research paper, again, it is meta-analysis where they found that GLP-1 agonists, along with or individually with SGLT2 inhibitors in PCOS patients who are non-diabetic or pre-diabetic, just obese PCOS individuals, definitely showed promising results because GLP-1 analog is actually acting at all aspects of PCOS, right from central, causing satiety, improving the GnRH pulse frequency, to attacking the hyperinsulinism pathway, and also at the level of granulosa cells, where it is improving the intra-ovarian hyperandrogenism, improving anthropometric parameters via the hyperinsulinism route. SGLT2 inhibitors also basically were good in reducing the body weight adiposities and the free androgen index. So these are the new drugs that have come up. Again, the take home messages would be the recent guidelines that the 2023 Rotterdam aims to avoid overdiagnosis, not to use AMH in the diagnosis of adolescent PCOS, not to use ultrasound, use hyperandrogenism and chronic anovulation as the criteria. The at risk PCOS candidates for preventive therapy research should be directed at this area, and how to identify the true PCOS from these at risk PCOS individuals. And chronic BPA exposure, this is another area of research. We don't have even our IV lines and the bags that we are using have been studied in IVF cases to increase the BPA level amongst the follicular fluid that is being aspirated. So we have high BPA exposure, and there are studies that are showing BPA causing PCOS. Those studies need to be done. Again, circular RNA as a potential biomarker. Look out for this one for diagnosis of adolescent PCOS. And finally, the newer drugs, the GLP-1 analogs and SGLT2 in obese and pre-diabetic PCOS to be done. Thank you.
Thank you very much, ma'am, for recent update. And we have to really very cautious regarding making diagnosis of PCOS, particularly in adolescent girl. Since they are coming to you with complaints, so individual complaint to be taken care of. So it doesn't, that not labeling PCOS doesn't stop you to treat or to help the person. Rather, you should label it at risk PCOS. And ma'am has rightly pointed out that there is no role of diagnosis on the basis of radiological or single AMH level. So these things we have to take care. And thank you very much, ma'am.
Thanks a lot. And it was a wonderful talk with regards to the recent developments in that regard. So, yeah, Dr. Soon.
Yes, very extensively covered presentation. I'd just like to highlight few points.
Yeah.
Just like dyslipidemia, PCOS is also is not only a menstrual disorder, it is a metabolic disorder with far-reaching consequences like ASCVD also. And just to mention that AMH should not be loosely prescribed, because only few labs have been accredited, given the license by FDA that correlate with the clinical thing, such that the Access lab by Beckman Coulter and the MinoCheck kit by the ANSH lab or the ARUP. These are the only three kits that have been approved with pre-approved cutoff levels. So only the standard lab the lab value should be taken in mind while making a diagnosis.
Absolutely. And when we talk about AMH in adolescence, it's mainly a surrogate of PCO appearance. So in a way, because that's not being considered as the primary thing, hyperandrogenism and anovulation is, so we should not be over excited by the AMH levels as you have.